To this session on case-based scenarios in medicine part 7. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and I hope that you guys are able to see me and hear me well. If you're able to see the screen well and hear me well, please leave a thumbs up in the chat box and we can proceed with today's class. I'm a gold medalist in anesthesiology. This is the Telegram channel that we have where you guys can join us. Let's crack NEET PG. So in this Telegram channel you will get the links to all the classes that I take. We take a lot of free classes so that you guys are able to keep your preparation on with the minimal cost. Now I have a very interesting thing for you guys, the NEET PG 2022 All India mock test. So you can see it's on the 26th of February at 9 AM, and this NEET PG 2022 All India mock test is going to help you make sure that your preparation for the exam is awesome, and you also know how well your friends have prepared for the exam, because it's going to give you a comparative ranking of your preparation. Then we also have the NEET PG Combat on orthopedics, OBGY surgery and pediatrics. The Plus subscription on Unacademy will help you get access to both live and recorded classes. You can learn from India's top educators and you can compete in live tests and quizzes. You can study on the device of your choice. The Iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the live lectures of Unacademy along with the video lectures of PrepLadder. These are our FMG toppers, and we have all the educator curated test series in medicine, in OBGY, orthopedics, anesthesia. So I hope all of you all gave the anesthesia test on 18th. It was very easy, and I hope that you all won some Amazon vouchers. In our special classes, we have interactive live classes, polls for the learners, raise a hand option, and also these are the plus batches that are going on right now. The NEET PG 2022 All Educator Revision batch, the Target Next 2023 subject wise batch. You can see me over here. I'm a part of this batch. And we have the Focus FMG comprehensive batch for December preparing students. So to buy the Plus subscription, you can use my code Dr.Jhanvi Live, which will help you get an extra 10% discount on your subscription. Now I'm really sorry if the system is looking a little different, because I'm using another computer. My problem has not yet been solved of the system, so I hope that the streaming on this is fine for you guys. Okay, so the first question we have for today is this. A 35-year-old female has been complaining of loose stools, bloating and passage of mucus in stools. She has recurrent abdominal pain which is relieved by defecation. Which of these is not considered as a red flag in this condition? Fever, blood in stools, weight loss, or onset in more than 35 years of age? So first of all, you all need to diagnose what is this condition, and then we will be discussing the entire red flags of this condition. Okay. Rameshwar is saying on D is the answer. Any other answers do we have? Okay, Mullah is also saying D. So if you guys are saying that D is the answer, can you tell me what would be the correct age group that would be considered as a red flag in the condition? So I think which of these is not considered as a red flag, correct? So fever is considered as a red flag, blood in stools is considered as a red flag, weight loss is considered as a red flag. So onset in more than 35 years of age is not considered as a red flag, correct? So onset in how many years of age is considered as a red flag? No, Rameshwar, this is not acute gastroenteritis. First of all, look at the patient profile. It is a female. Females generally have a lot of anxiety issues. Okay, what is she complaining of? Loose stools, bloating, passage of mucus in stools, and recurrent abdominal pain. So these 4 symptoms, can you put it together and tell me what is the answer to this? So this is nothing but irritable bowel syndrome. Okay, irritable bowel syndrome, classical presentation. Can anyone tell me how do you diagnose irritable bowel syndrome? What is the accurate definition of irritable bowel syndrome. Yes, no, staphylococcus, you are wrong. If the onset is more than 50 years of age, then that will be considered as a red flag. Why? Because your ulcerative colitis, your Crohn's disease, then your cancers of the GIT, all of them are in older patients. Okay, so more than 50 years of age, older patients. So when you start getting these symptoms in older patients, you should start thinking more on the lines of malignancy. Yes, yes, staphylococcus, this is irritable bowel syndrome. So, how many times in a month, according to the definition of irritable bowel syndrome, how many times in a month should she have complaints like this of loose stools, bloating, mucus, abdominal pain? Textbook definition, anyone? Batao? Alright, so I'll give you the answer. So it should at least be for 3 times a month. Okay, so she should be presenting with these symptoms at least 3 times a month. Now, what are the various presentations of irritable bowel syndrome? Either the patient can present with constipation, or the patient can present with diarrhea, or she can present with pain in abdomen, just pain in abdomen. Okay, no diarrhea, no constipation, just pain in abdomen. So can you tell me what would be the treatment for these individual conditions of the patient? What will you give for constipation, what will you give for diarrhea, and what will you give for pain in abdomen? If they ask you what will be your treatment for all of these, what will you give for constipation, what will you give for diarrhea, and what will you give for pain in abdomen? ORS, monoclonal antibodies and antipyrexic? No. Yes, very good, Rameshwar. So for constipation, you can give either psyllium husk. Psyllium husk is nothing but isabgol. Okay. And you can also give lactulose syrup. So lactulose syrup is nothing but a stool softener. So that will help in constipation. Okay. For diarrhea, what can you give? For diarrhea, we can give loperamide to the patient. And for pain in abdomen, what can we give? For pain in abdomen, we can give them smooth muscle relaxant. Okay, so any kind of smooth muscle relaxant like cyclopam will help in reducing the pain of the patient. Okay, so this is all about irritable bowel syndrome that you need to know. What is the presentation? Presentation is either as constipation or as diarrhea, and along with that there will be pain in abdomen and passage of mucus in stools. That is the classical presentation of IBS, and the minute the patient passes stools, the pain will be relieved. Okay, but when do you stop thinking of this as irritable bowel syndrome and start thinking of it as a red flag? When the patient starts presenting with features like fever, blood in stools, weight loss, and onset in older age groups. Okay, so coming on to our next question. A patient comes with alternating diarrhea and constipation since 3 months. A colonoscopy is done and this is the picture. He also has some abnormal spots on his face. What would be the part of the GIT most involved in this condition? Stomach, appendix, small intestine, or large intestine? What would be the answer in this? Stomach, appendix, small intestine, or large intestine? And identify the condition. Okay, so we have Staphylococcus saying that it is a condition of the large intestine, Giri Chaitanya saying it is a problem of the small intestine. So first of all, can you tell me what can you see in these two pictures and what is the condition we are talking about? Yes, correct, Mulai, correct, Staphylococcus. So the condition we are talking about over here is Peutz-Jeghers syndrome. Okay, Peutz-Jeghers syndrome. Now look at the presentation of Peutz-Jeghers syndrome. There is diarrhea, there is constipation, and also some spots on his face. Can you tell me what do you call these spots on the face exactly? And what do you call this appearance on colonoscopy as? Okay, so the spots that you can see on the lower lips are called as nothing but mucocutaneous pigmentation. Mucocutaneous hyperpigmentation. Okay, so here you are going to have hyperpigmentation on the lips and you are going to have hyperpigmentation on the mucous membranes. And when you do a colonoscopy, what do you see over here? You can see the presence of these polyps. So these are nothing but hamartomatous polyps. Okay, hamartomatous polyps that are seen in these patients. So hamartomatous polyps plus oral mucocutaneous hyperpigmentation are, along with diarrhea and constipation, are seen in Peutz-Jeghers syndrome. Now, no one has given the, some of you all have given the correct answer. So Giri Chaitanya and Mulai have answered correctly that in Peutz-Jeghers syndrome, the part that is affected is nothing but the small intestine. Okay, so whenever you revise GIT, see, everyone is going to know that this is Peutz-Jeghers because of the very characteristic mucocutaneous hyperpigmentation, but you have to remember which part exactly of the colon is affected. Is it small intestine, is it large intestine, is it stomach, appendix? Exactly you should know, because there's no point knowing or diagnosing the syndrome and not knowing the under ka information about it, which they are going to ask in the exam. Okay, now look at this similar question and similar options, and you need to identify. A patient comes with alternating diarrhea and constipation since 3 months. A colonoscopy is done and this is the picture. He also has recent history of onset of seizures. His CT scan is given below. What would be the part of GIT most likely affected in this disease? Stomach, appendix, small intestine or large intestine? Yes, Rameshwar, you are right. Jejunum is most commonly affected in Peutz-Jeghers syndrome. So identify what is the condition in this patient. Okay, very good, Mulai. So Mulai has absolutely correctly identified the condition. So this is nothing but Turcot syndrome. Okay, so Mulai, can you tell us what are the features of Turcot syndrome? What are the features of Turcot syndrome, Mulai? Some of the features obviously have been mentioned in the question. There is diarrhea, there is constipation, just like all other conditions of the GIT, alternating diarrhea and constipation. And he is having recent history of onset of seizures, and I've given you a picture of the CT brain. Okay, so what can you see on the CT brain? Any idea? And what can you see in the colonoscopy? In colonoscopy, it's very obvious, you can see the presence of many polyps. But what can you see in the CT brain? Yes, very good. So here can you see this part over here? This is nothing but an intraparenchymal tumor of the brain. Okay, so intraparenchymal tumor of the brain, that is causing irritation of the parenchyma of the brain, and that is why you are having the seizures. Okay, so polyps in the GIT along with tumor in the brain, this is nothing but Turcot syndrome. Okay, so which part of the intestine is affected in case of Turcot's? Is it stomach, appendix, small intestine or large intestine? What is the answer? Mulai and Rameshwar are saying large intestine. Any other answers? Come on, staphylococcus, what is your answer? Staphylococcus, what is your answer? Which part of the intestine is affected? Alright, so in Turcot syndrome, the part of the intestine that is affected is nothing but the large intestine. Okay, so we saw in Peutz-Jeghers the small intestine was affected, but in Turcot's the large intestine will be affected. Okay, alright, next one. So another similar patient. A patient comes with alternating diarrhea and constipation since 3 months. Colonoscopy is done. This is the picture. He also has abnormal jaw formation. What would be the part of the GIT most likely affected in this disease? Stomach, appendix, small intestine or large intestine? Okay, so diagnose this disease and tell me which part of the colon is affected in this. Okay, staphylococcus is saying C, and he's saying that this looks like scurvy. No, this is not scurvy. At least in the colonoscopy, you guys can identify that there are presence of multiple polyps. Okay, so look at the case presentation: alternating diarrhea and constipation. And something is wrong with the jaw. I have given you an X-ray of the jaw over here. So what can you identify? Mulai is saying answer is large intestine. But can anyone diagnose the condition for me? Okay, so let me give you guys some hint. Can you see there are presence of multiple teeth that are present over here? So there are supernumerary teeth. Supernumerary teeth. That is one thing. And also the jawbone seems to be malformed because of hypertrophy. Okay, so that is called as osteomas of the jaw. So now can you guys put these three things together and tell me what is the condition? Osteomas of the jaw, supernumerary teeth, polyps in the colon, and one more thing I'll give you, there are also present of multiple lipomas in this condition. Anyone, can you diagnose the disease for me? Yes, very good, staphylococcus. So here the diagnosis is nothing but Gardner's syndrome. Absolutely correct. So this question is about Gardner's syndrome. So are you seeing all the diseases are presenting with similar GI complaints: alternating diarrhea, constipation, and polyps in the intestine, but they affect different parts. They either affect the small intestine or the large intestine, and along with that there is always one feature which is very characteristic. Like in Gardner syndrome you get osteomas, in Turcot syndrome you get brain tumors, in Pseudocyst syndrome you get mucocutaneous hyperpigmentation. So these small specific details that are there, you should be remembering it so that it helps you get good marks in the exam. Okay, alright, so now since we have diagnosed this as Gardner's syndrome, can you tell me what is the part of the intestine that is affected in Gardner's syndrome? Is it the stomach, appendix, small intestine, or large intestine? So Pseudocyst was small intestine, Turcot's was large intestine. This 50-50% chance of deciding what is the answer. जय माता दी करके बोल दो क्या है आंसर. Okay, so Mulai, Atmesh are saying staphylococcus. All of them are saying that the large intestine is affected. That is absolutely correct. In Gardner syndrome also your large intestine only is affected. Okay, absolutely correct. Okay, now moving on to our next question. A patient comes with excruciating abdominal pain radiating to the back. His serum amylase levels are elevated. 2 days after his admission, there is sudden loss of vision. What is the cause of loss of his vision? Anterior retinal artery occlusion, posterior retinal artery occlusion, optic nerve entrapment, or mass in the occipital cortex? Okay, so Rameshwar and staphylococcus is saying answer is D. No, that is the wrong answer. Then Rameshwar is changing answer to B. Okay, first of all, try to identify what is the problem in this. Can anyone identify the problem for me? What is the condition? Silent killer, definitely JE is better. The grass is always greener on the other side. Okay, are you guys able to see me and hear me properly? Okay, yes, absolutely correct. So what are we talking about here? If there is excruciating abdominal pain radiating to the back, okay, so this is nothing but pancreatitis, and since the serum amylase levels are acutely elevated, this is nothing but acute pancreatitis. Okay, so in acute pancreatitis, what is the name of the condition in which you will have loss of vision? So as correctly mentioned by Mulai, okay, so the name of that condition is nothing but Peschner's retinopathy. Peschner's retinopathy. Okay, so in Peschner's retinopathy, what happens? Because of the pancreatitis and the inflammation, there is a sudden increase in the number of granulocytes. Okay, and what do these granulocytes do? They go and they clog or they obstruct the flow of blood, especially in the posterior retinal artery. So they cause posterior retinal artery occlusion. Okay, so as a result of posterior retinal artery occlusion, what happens is that there will be less flow of blood to the eye, and that can cause loss of vision. Okay, so in Peschner's retinopathy, you have posterior retinal artery which is occluded. So remember that for the exam. Alright, okay, moving on to our next question. A patient comes with excruciating abdominal pain radiating to the back. His serum amylase levels are elevated. 7 weeks later, a CT scan shows presence of a pseudocyst. Which of these is a criteria for pseudocyst of pancreas drainage? Pseudocyst more than 2 cm in diameter, pseudocyst more than 6 weeks old, shrinking pseudocyst, or all of the above. Okay, JEE is better because you have better chances of settling early in life, isn't it? Okay. Akanksha, are you sure about the answer? Which of these is a criteria for pseudocyst of pancreas drainage? Alright. So remember that if the pseudocyst is shrinking in size, definitely you are not going to cause drainage of the pseudocyst. Okay, it's going to resolve on its own, so there is no need to do this. Make sure that you resolve the pseudocyst. Then if a pseudocyst is more than 6 weeks old also, but it's not causing any symptoms, then there is absolutely no need to cause drainage of the pseudocyst. But this is one of the criteria that you should be focusing on. Okay, so if the I'm so sorry, 1 second. So if the pseudocyst is more than 6 weeks old and it's not resolving on its own, okay, it's not resolving on its own, so you will have to drain this pseudocyst. Okay, so it is a criteria for drainage of the pseudocyst. And when do you drain a pseudocyst as per the size? If the size of the pseudocyst is more than 5 cm in diameter, that is when you take the pseudocyst of pancreas for drainage. Okay, so if the pseudocyst is resolving on its own by shrinking, no need to do anything. If the pseudocyst is becoming very large in size, to be specific more than 5 cm in diameter, then you need to drain the pseudocyst. And if it is a old pseudocyst not resolving, you have to take it up for drainage. Okay, so the answer is B over here. Alright, and the answer is not all of the above, remember it. Okay, next question. A 50-year-old man has recent history of onset of sweating, tremors, palpitations, confusion, headache and disorientation. These symptoms are improved on eating a full meal. A 72-hour fast test is done for this patient. What would be the ideal insulin levels to make the diagnosis? Serum insulin levels more than 2 microunits per ml, serum insulin levels more than 4, more than 6 or more than 8 microunits per ml. First of all, identify what is the CT showing you, try to identify what is the condition that we are talking about, and then tell me the answer. So why is he getting the sweating, tremors, palpitations, confusion, headache and disorientation? All these are symptoms of what condition? Any idea? And the symptoms are getting improved whenever there is intake of carbohydrates or glucose. Yes, very good, Akanksha. So on the CT you can see a pancreatic mass, and what do you think could be this pancreatic mass? Excellent. So this is an insulinoma. Okay, so these symptoms of sweating, tremors, palpitation, confusion, headache, disorientation are nothing but symptoms of hypoglycemia. Okay, and these symptoms are getting better when he has carbohydrate intake or whenever he has glucose intake. So these symptoms are diagnostic of an insulinoma, which you see growing on the pancreas. So can you tell me, when you do a 72-hour fast test, according to the guidelines, what is the ideal insulin levels to make the diagnosis? So NAN-PK is saying serum insulin levels more than 6 microunits per ml. Sorry, any other answers? Ideal insulin levels to make the diagnosis? See, ideally, if the patient is fasting for 72 hours, his serum insulin levels should be quite low, okay, because he's not eating anything, he's already hypoglycemic, so production of insulin should be less. But if you have a tumor that is producing insulin continuously, that level of serum insulin should be on the higher side than normal. So what is the answer? Staphylococcus is also saying C, 7 to 8. Okay, so the correct answer over here is, if on diagnosis the serum insulin levels is more than 6 microunits per ml, that means you are having an insulinoma. Alright, okay, there are also other things that you need to check. You can check the C peptide levels, and you can also check the serum glucose levels of this patient. Okay, so you will see that this patient is dangerously hypoglycemic after a 72-hour fast. So usually his glucose levels will be less than 40 mg per dl. Okay, so all of these will, when after the 72-hour fast test, when you test all of these blood investigations, you will be able to conclude that this is presence of an insulinoma on the pancreas. Alright, okay. Next question. In Werner-Morrison syndrome, which of these electrolyte abnormalities are not seen? So first of all, what is Werner-Morrison syndrome? What happens in Werner-Morrison syndrome, and what are the electrolyte abnormalities that you see and do not see in Werner-Morrison syndrome? Batao. Sorry, I am not able to read your comments. Okay, very good, Akanksha. So Werner-Morrison syndrome is nothing but excessive production of vasoactive intestinal peptide. Okay, so it is nothing but a VIPoma. Can you tell me the other name of Werner-Morrison syndrome? That will in fact tell you the yes, VIPoma. It causes diarrhea. Absolutely correct. So it causes watery diarrhea, and that's why it's also called as WDHA syndrome. Okay, now what are the symptoms that you'll see? One is watery diarrhea, and if I do lab investigation of the patient, what will happen to the potassium levels, what will happen to the H+ levels in the body? And what is the electrolyte abnormality that you will not see over here? Electrolyte or serum abnormality, because here I have given you sugar, so that does not necessarily become a part of electrolytes. Okay, so is hypokalemia present? If the patient is having watery diarrhea, will he lose the potassium, or is hyperkalemia present? Okay, so we have many different answers over here. Okay, let's take one by one option. Is hypokalemia present or is hyperkalemia present? I already told you, because of the diarrhea, the potassium levels will fall. Okay, so there will be hypokalemia in this syndrome. Absolutely correct. Is there achlorhydria? Yes, hydrochloric acid levels that are produced by the parietal cells in the stomach will be less. So again, you will have achlorhydria also correct. Is there hypocalcemia or hypercalcemia in this condition? what happens to the calcium? Any idea? No, Rameshwar, hyperglycemia is seen, so that is also the correct answer, but the calcium levels in this condition will increase. Okay, so there is hypercalcemia in WDHA syndrome or Werner-Morrison syndrome. There is no hypocalcemia. Okay, so the correct answer over here is this. So which electrolyte abnormality is not seen? You don't see hypocalcemia. In fact, you see hypercalcemia. So remember, you will have hypokalemia and achlorhydria on the lower side, and on the higher side you will have hypercalcemia and hyperglycemia in WDHA syndrome or VIPoma or Werner-Morrison syndrome. Alright? Okay. Moving on to our next condition. A 35-year-old female presents with recurrent abdominal pain, diarrhea and GERD. There is no relief with proton pump inhibitors. She has tested negative for H. pylori infection. Which of these tests is not useful in this disease? Secretin stimulation test, gastrin stimulation test, histamine stimulation test, or all of the above tests are useful? So, if you are suspecting, Ravi Kumar is saying all of the above tests are useful. Okay, see, she is having GERD and she is having recurrent abdominal pain, and it is refractory to the treatment with PPIs. So with these three things, what is the diagnosis that you can start thinking about? H. pylori is absent in her. She is probably having gastric ulcers which is causing the abdominal pain, but it is not responding to PPIs. So what do you think would be the answer to this? Is there any tumor that you guys can think about in this case? Is there any tumor that you all are thinking about over here? Yes, absolutely correct. So it's possible that she is suffering from Zollinger-Ellison syndrome. Absolutely right. And if she is suffering from Zollinger-Ellison syndrome, what will you be suspecting? You will be suspecting that her gastrin levels will be very high. Okay. So now if you want to check the serum gastrin levels, obviously gastrin stimulation test will help. Secretin stimulation test will also help, but will histamine stimulation test help? No, that is not going to help in this case. If you stimulate the histamine, it is directly going to release hydrochloric acid. It's not going to give you any idea about the gastrin levels. Okay, so your histamine stimulation test is the one that is not useful in case of Zollinger-Ellison syndrome. So first of all, don't get carried away by option D, all of the above, none of the above. Okay, so that's something that you need to get out of your head, because they use this option a lot to make sure that you all make mistakes in the exam. Okay, so histamine stimulation test is not going to be useful for diagnosis of Zollinger-Ellison syndrome. Okay, next question. Which of these is not a part of Ranson's criteria at admission for prognosis of acute pancreatitis? Age more than 55 years, fall in hematocrit more than 10%, hyperglycemia more than 200 mg per dl, or leukocytosis more than 16,000 per microliter. Okay, so Nimesh is saying answer is B. First of all, in Ranson's criteria, there are some things that need to be tested at admission, and there are some things that need to be tested after 48 hours. Correct? So I have given you all the mnemonic for remembering both of them. So what is the mnemonic for remembering the conditions that have to be tested at admission? So just remember this mnemonic. Always at admission you should always test the glucose of the patient. Okay, so at admission you should always test the glucose of that patient. Now why am I saying always? Just remember ALW and then we have AYS. Okay, so what does the first A stand for? First A stands for age, then we have L for LDH, we have W for WBC count, and I have taken the AYS. Just remove the Y over here and keep the AS, and this is AST levels. Okay, and the last thing is, I told you, always test the glucose of that patient. Okay, so blood glucose levels. So these are the criteria that need to be checked at admission in a patient of acute pancreatitis. This is a part of the Ranson's criteria. So we have age over here, we have hyperglycemia over here, so blood glucose levels, and we have leukocytosis, so the WBC count over here. But fall in hematocrit is actually a part of the Ranson's criteria after 48 hours and not at admission. Okay, so that is how you will remember Ranson's criteria. Okay guys, alright. Moving on to our next question. A patient presents with melena, anemia and weight loss since 15 days. His sigmoidoscopy on biopsy shows presence of flask-shaped ulcers. What will be the treatment for the same? IV ceftriaxone, IV augmentin, IV metronidazole or IV clindamycin? Okay, I think this was too easy for you all to diagnose because I've even given the sigmoidoscopy findings on biopsy. Yeah, so you have presence of flask-shaped ulcers, correct? So these flask-shaped ulcers are seen in case of, in which condition do we see flask-shaped ulcers? Yes, so flask-shaped ulcers are seen in case of typhoid. Okay, so we are talking about typhoid ulcers over here, and what will be the treatment for the same? We will be giving the patient IV ulcerative colitis. No, so we will be giving the patient IV metronidazole. Alright, okay. Moving on to our next question. So now I want you guys to identify this disease for me and tell me the inheritance pattern of this disease. This was recently asked in either the FMG exam or the NEET PG. No, I think it was asked in FMG exam. Yeah. Yes, absolutely correct. So the stretchy skin that you see in this patient, very classical of Ehlers-Danlos syndrome, correct? What is the inheritance pattern of Ehlers-Danlos syndrome? Anyone? Yes, it is autosomal dominant in nature. Okay, now can you tell me what are the cardiac manifestations of Ehlers-Danlos syndrome? Cardiac manifestations of Ehlers-Danlos syndrome? Batao. Why do you get the stretchy skin? It's basically because of faulty collagen production, correct? So in this case, what will be your cardiac manifestations? Okay, so the most common cardiac manifestation that we see in a case of Ehlers-Danlos syndrome is nothing but aortic stenosis. Alright? Okay. Moving on to our next picture. So identify this machar and what is the diseases that it carries. Yes, absolutely correct. All of you are right. So what do you see in case of this mosquito? This is nothing but Aedes aegypti mosquito. Okay, so you are seeing the tiger stripes. So the tiger stripes are seen in case of Aedes aegypti mosquito. Alright, what are the 4 diseases that are carried by Aedes aegypti mosquito? Anyone? 4 diseases carried by Aedes. I'll give you the easiest one. Dengue, chikungunya. Anything else? Yellow fever and Rift Valley fever. Okay, so guys, I'm just pointing out a small mistake made by me over here. Okay, I'm really sorry about this. Rameshwar, thanks for pointing it out. These flash shaped ulcers are not typhoid ulcers, they are ulcers caused by Entamoeba histolytica. Okay, so these are ulcers of amoebiasis, and that is why the treatment would be IV metronidazole. Okay, if you would have typhoid ulcers in the intestine, what would your treatment be? Typhoid ulcers in the intestine would be treated with IV ceftriaxone. Okay, so these are nothing but your amoebiasis ulcers which are treated by IV metronidazole. Sorry, even I have to read for so many subjects that many a times I get confused. That is the difference between someone who is giving NEET PG and someone who is not giving NEET PG. The focus with which they read. Alright. Okay. What is this mosquito and what are the diseases that are carried by it? Ravi Kumar, I did not understand your comment. Yes, absolutely correct. Nan PK. So this is nothing but a Culex mosquito. How do you identify the Culex mosquito? Anyone? Yeah. So can you see there is a presence of a hunchback over here? The angle between the head and the body. So this is a hunchback that is present. Okay. So this is the Culex mosquito. What are the 2 diseases that are carried by Culex mosquito? Diseases carried by Culex. You have Japanese encephalitis and Japanese encephalitis and West Nile fever. Absolutely correct. Okay, next Machar. This is the one that we get a lot in India. See the angle between the head and the rest of the body. Keep my phone like this in view so that I can see you guys straight instead of looking down every time. Okay, so between the head and the body, the angle that you can see is approximately 45 degrees. So this is your Anopheles mosquito. And what are the diseases carried by Anopheles mosquito? It is nothing but malaria and filaria. Okay, alright, moving on. So this is the table which will give you the different types of mosquitoes and the diseases carried by them. Now I want you guys to identify this condition. So there is a 60-year-old female and she is coming to us with menorrhagia and syncopal attacks and lower abdominal pain. Can you identify what is she suffering from? Menorrhagia, lower abdominal pain and syncopal attacks. What is the condition and how will you treat it? Okay, Ravi Kumar, is it a simple fibroid or is it something else? Okay, so this is actually a calcified fibroid. Okay, this is nothing but a calcified fibroid. And what will be the treatment for this? Either you'll do a myomectomy if it's a single fibroid and it's not very large in size, but if it is much bigger in size and there are multiple small fibroids also that are present, you can go ahead with a hysterectomy for this patient. Okay, all right, moving on to our next condition. So this is one of the questions that was asked recently in the NEET PG exam, and they had asked specifically that when you do a lumbar puncture, what is the last structure that you pierce? So let's see, when we give spinal anesthesia or when we do a lumbar puncture, okay, so in that time, where is the space that we are focusing on? So the space that we are focusing on while we do a lumbar puncture or we give spinal anesthesia is nowhere but the subarachnoid space. It's the subarachnoid space. Okay, so what are the layers that you have to cross to reach the subarachnoid space? Anyone? What are the layers to be crossed to reach the subarachnoid space? So you have the skin, you have the subacute tissue, okay, then you start off with the ligaments. So you will have the supraspinous ligament. The supraspinous ligament is this ligament that is present over the spinous processes. Okay, then once you cross the supraspinous ligament, the next will be this part, the interspinous ligament. Interspinous ligament. Once you cross the interspinous ligament, then the next ligament that comes on the inside is nowhere but ligamentum flavum. Okay, once you pierce the ligamentum flavum, you will feel a give way and you reach into the epidural space. That is the epidural space. Okay, now the rest I am going to write it on the other side. So once you have entered into the epidural space, the next thing to be punctured is nothing but your dura mater. Okay, that's why when you pierce for spinal anesthesia or you pierce for a lumbar puncture, you will feel two loss of resistance. One is when you pierce the ligamentum flavum and enter into epidural space. The second is when you pierce into the dura and enter into the subdural space. Okay, so after the dura you have the subdural space, but you have to go beyond this. You have to pierce into the arachnoid mater and you have to enter into the subarachnoid space. There is no sound, there is no pop or sound, there is just a loss of resistance feeling. So once you reach into your subarachnoid space, this is exactly where you have to give your spinal anesthesia or lumbar puncture. Okay, and if they ask you epidural space, then the last thing that you will pierce for that is ligamentum flavum. So you should know each and every part of this. Please remember it for your exam. Okay, all right. Identify the condition in this patient and the causative organism. Okay, very good, absolutely correct. So what is this appearance that you see of the eyelid? This is called as nothing but sabudana appearance. Okay, what is sabudana appearance? That is nothing but boiled sago grain appearance. Okay, and where do you see boiled sago grain appearance? We see boiled sago grain appearance in trachoma, leading cause of blindness. Okay, and that is caused by chlamydia trachomatis. Okay, anyone, what will be the treatment for this? Any idea what is the treatment? Meanwhile, we can move on to the next question. What is the condition that this child is suffering from, and what is the genetic inheritance? What is the condition that the child is suffering from? What is the genetic inheritance? Yes, very good, Mulai. So this is nothing but xeroderma pigmentosum. Okay, and what happens in xeroderma pigmentosum? It's nothing but a DNA repair defect. So as a result of this, the skin is not formed very well. What is the genetic inheritance? Genetic inheritance is autosomal recessive. Okay, all right. Moving on to our next condition. Okay, so this patient is coming to me with fever, vomiting, neck stiffness. What is the causative organism? Anyone? Yes, absolutely correct. So what can you see over here? You can see presence of gram-negative diplococci, and the patient is presenting with symptoms of meningitis, correct? So this patient is suffering from meningitis due to Neisseria meningitis. All right? Okay. Diagnosis and treatment also you can tell me. Yes, no, these are not. Okay, so you can see the orphan annii nuclei over here. Okay, I didn't show you the entire picture. So orphan annii nuclei is seen in papillary carcinoma of thyroid, correct? What will be your treatment for this? Treatment for this will be thyroidectomy, correct? Okay. Next condition, what is this patient suffering from? You can also see Samoma bodies in papillary CA thyroid, but that's not very specific for papillary CA thyroid. It can also give you condition diagnosis of serous cystadenoma of the ovary and meningioma, but your orphan annii nuclei is specific for papillary CA thyroid. Yes, absolutely correct. So what is this? You're seeing the white lacy appearance or white lacy pattern on mucous membranes, especially your buccal mucosa. So this is characteristic of lichen planus, correct? This is characteristic of lichen planus. Okay, can you tell me what are the 5 P's of lichen planus? How are the lesions of lichen planus? बताओ. So they are purplish lesions, they are planar, they are papular, they are pruritic, they are polygonal. Correct? Are you missing out on anything else? Purplish, planar, papular, pruritic and polygonal. Okay, moving on to our next condition. This is a farmer, and after 6 months of working in his field, this is the condition that he is suffering from. So what is the causative organism? This causative organism has a very peculiar name. Yes, very good. So this is Madura foot or Mycetoma foot. What is the causative organism? The causative organism is nothing but Actinomadura madure. Okay, Actinomadura madure. Alright. What is this pattern of hair loss that this patient is suffering from? Yes, very good. So you can see that there is hair loss and patches over here. So in particular areas, so this is called as alopecia areata. Okay, so you have the exclamation mark sign over here that you see in alopecia areata, and alopecia areata is associated with which dermatological disease? It is associated with lichen planus. Okay, so this is alopecia areata with exclamation hair mark sign. Alright, okay. This condition is seen due to excessive deposition of what? Very good, staphylococcus. This is case of Fleischer ring. What is getting accumulated in the Descemet's membrane? Yes, there is excessive deposition of copper in the Descemet's membrane. Okay, now can you tell me what would be the treatment for this? Don't just say chelating agents. What exactly is the name of the chelating agent? Yes, absolutely correct. So the chelating agent that you will be giving is D-penicillamine. Okay, and the last question for the morning class. Remember, we also have a class at 8 p.m. case-based scenarios part 8. Okay, so that is at 8 p.m. today. It's on YouTube only. I'll share the link with you guys. So this is the endotracheal tube, and I want you guys to tell me that what kind of cuff is this. First of all, you have to tell me the type of cuff. Then you have to tell me what is the use of this radio opaque line. The black radio opaque line that you can see, what is the use of this radio opaque line, and what is the use of this extra hole that is there over here? What is the name of that extra hole and what is the use of that extra hole? Yes, absolutely correct. So this radio opaque line is basically to look at the X-ray identification of the tube. So is it in proper position or not? Has it gone endobronchial or is it correctly placed or not. Okay, what is the extra hole for? Okay, what is this called? It is called as the Murphy's eye. Okay, what is the use of the Murphy's eye? If ever your tube gets obstructed over here, if there is an obstruction of the tube at the distal end, then your Murphy's eye will help in serving as an alternate mode of ventilation. Okay, alright, and finally, what is the type of cuff that we see? This is a low pressure, high volume cuff. Remember this is a low pressure, high volume cuff. Alright, so that's it for today's class, and I shall see all of you guys at 8 p.m. tonight for the next session on case-based scenarios and image-based questions. And I hope that you guys like this class. Please don't forget to see the previous parts and leave a thumbs up at the end of the class if you liked it. I shall see you at 8 p.m. Bye guys.